feels good to share a challenging left main bifurcation caused by ostial LAD stent failure. The presence of world expert in this meeting will enlighten us to discuss the appropriate strategy in dealing with these particular bifurcations. Let me start. This is a 58 years old diabetic male present with non-ST elevations. LVS was 46%. He has grade 2 internal hemorrhoid and previous PCI 1 month ago before index procedures at other institutions. And there was an ostial LAD stenting. Syntax score was 29, syntax 2, as you can read here, and Euro score 2.3. This is a moderate syntax score. So this is the previous PCI. As you can identify here, there is a severe stenosis of the LAD. And at that time, the operator putting a 275/28 DS at nailing at the ostial part. So you can appreciate here at that time. And then after implanted, you can see here. So angiographically looks a good result. After previous PCI, 4 months after the first PCI, patient suffer angina on effort. He keep on DAPT at that time, clopidogrel and aspirin, and his cardiologist optimized medical treatment. But 3 weeks before last procedures, he stopped DAPT due to rectal bleed. And 5 months after previous PCI, he was admitted to our hospital due to non-ST elevations. This is at the time when came to our hospital, and this is a left system dominant. You can appreciate here, there is a very tight stenosis at the left main, and there is as well severe stenosis exactly at the distal stent edge. So this is the caudal view, looks through left main bifurcations involving ostial left LAD and ostial circumflex. So there is a revascularization option, PCI or KBH. At that time, we stopped the procedures and discussed with the patient and family regarding the revascularization options. And the patient insists to have a PCI. So we prepare using a 7 French EBU 3.5 transfemoral approach, IBP support, and we perform OCT, LAD, and circumflex after pre-dilatation using 2.0 millimeter balloon. You can appreciate here, this is the OCT run from LAD to left main, demonstrated that at the mid-distal LAD, you can see here, there was a lot of disease, fibrotic disease. So look at the stented afterward, we came to the stented segment, and there's some dissection because of pre-dilatations. So it's possible that the previous stent landing at a huge plaque burden, and the stent was not well expanded. There is a fibrotic tissue growth, and there is some unlayered strut. And the LAD ostium, we'll come to the LAD ostium, look very severe disease. So this is the circumflex run. OCT pullback from the circumflex to a left and showed diffusely disease as well. The LCx ostium look tight lesion with thrombotic appearance. So what's your strategy regarding the putting the nail the stent at the ostial and hanging at the left main? And this is afterward, there is some diffusely disease involving the ostial LAD, ostial circumflex. So please share your strategy.
This is one of the most common dilemmas when we see isolated lesion at the ostium of the LAD or the circ. We still don't have universal acceptance of what is the preferred strategy. Of course, there are two possible options. In your case and in several others, there is attempt of the operator to precisely nail the stent at the ostium of the LAD, or the other strategy is crossover stenting. In this specific case, at the follow-up, we see acute coronary syndrome, very complex anatomy, and I'm really eagerly waiting to see what is the European perspective. And I would like to invite Professor Marek Ferenc to share the screen and present his approach in this case.
Okay, thank you. Yeah, Goran, thank you. This is as you mentioned, there are definitely two, maybe even three solutions for this patient, for this young patient. If I just summarize the important anatomical points. So first of all, there's a short left main. We saw from the area in OCT, it will be something between 4.0 and 4.5 diameter. And left main, as I mentioned, is short. There is a problem with in-stent long diffuse in-stent restenosis, starting with subtotal stenosis of LAD ostium. There is, as we saw in OCT, there is a longer part behind the stent with segment of dissection. So we have to treat also this segment. There are two diagonal branches. The second one is a bit larger. They should be, from my perspective, be open. And there is a huge dominant LCx, and with subtotal stenosis. We saw after first presentation, there was some compression here of ostial circ. And so if we see running movies, we could imagine the circ is still supplying viable myocardium. At least in LAD region, there is hypokinesia, or maybe partially akinesia. We don't have now MRI data for this segment. And from my perspective, from our perspective, it's very clear we have to rescue the connection left main to circ. This is for this patient extremely important. And of course, we should try to get here complete revascularization due to young patient. We know also some bleeding history, so this is, I think, also important point. Normally, we should discuss this case with surgery, but the patient refused a surgery. And regarding for the syntax score 2, there were similar outcome according Cabbage and PCI. So definitely you need to focus your attention to left main to LCx. And of course, 7 French will be better. Imaging after initial predilatation, important, definitely very helpful to understand anatomy and to understand diameter, and the ostium of LCx is also important in this topic. And from my perspective, it should be important to avoid stent-in-stent implantation here in this proximal LAD. And we also should try to keep diagonal branch. But the focus is to go with modern stent, and I would suggest this will be, from my perspective, at least in our center, the first choice will be Onyx. Also due to short DAPT treatment, and you go with predilatation, then imaging, you have to wire LAD. So this is here maybe step-by-step approach. So you place the wire in circ. This is most important point. Try to avoid to cross between struts. Then you go with a second wire to the LAD, also trying not to go under the struts. Predilatate the circ. I would go here with 3.0 balloon to have really good flow to the circ. then I would take 3.5 stent from left main to circ. This is the question, should be covered complete left main. This is very short, around 8 millimeters left main. So I would try to cover from the ostium to the circ, perform POT with minimum 4.0, maybe 4.5 millimeter, recross to the LAD, treat LAD in-stent with drug-coated balloon, probably stent here one more stent to the distal first stent, try to keep open diagonal branch, perform final kissing and final POT. And again, I think imaging will be very, very important. And I would recommend definitely to make re-angio after 6 months to check this complex anatomy. Thank you so much.
Okay, thank you very much, Professor Ferenc. So one strategy cannot fit for all. I mean, that we have here from Japanese Bifurcation Club, and I invite Dr. Yoshihisa Konishita for his perspective dealing with this very complex anatomy of the left main.
Thanks so much. Thanks for your invitation. Before this meeting, I and Dr. Murasato discussed about this case, and we summarized our strategy. Could you show me my presentation video?
Hi everyone, I'm Yoshihisa Kinoshita. It's my honor to join this meeting. In this session, I would like to talk about the approach and strategy for this case from JBC. This case is 58 years old male, and the target regions are 111 left main distal bifurcation, including ostial LAD ISR and mid LAD ISR. We think that the key point in this case is how we should treat circumflex ostium. OCT image from distal LAD showed circumflex ostium was jailed partially by the stent strut of proximal LAD. How to deal with this situation is very important to get an optimal result in this case. We showed the strategy from JBC here. First, we will make 3 OCT reconstruction images around left main bifurcation to figure out the relationship between jailed strut and circumflex ostium. And then we try to recross the wire into circumflex at the optimal point. After passing the wire, we dilate the proximal circumflex with cutting balloon or non-compliant balloon. Then we dilate proximal and mid LAD with cutting balloon. If condition of left main to LAD is acceptable, we will use the DCB for both LAD and circumflex. If dissection occurred in left main to LAD, we will perform the crossover stenting in left main to LAD. And if dissection was also recognized in circumflex, we will perform long inflation with auto perfusion balloon to avoid the complex stenting. However, if we cannot get the optimal coronary flow, we will perform the complex stenting like culotte or mini crush. Thank you for your attention.
Thank you very much, Dr. Kinoshita. So we have panelists here. So I would like to invite Prof. Santoso.
Yes. I think everything has been well explained. So this is just a very simple thought of mine. We all know that we can follow many recommendations and clinical studies, and the results, also the results of EBC as well as DK class 5. So I think I would applaud Dr. Fauzi for explaining the patients very much in detail, because we know that one size doesn't fit all. Patients may have different clinical risk, And Dr. Fauzi has clearly explained the risk stratification of the patients. Patient has ACS, EF, bleeding risk, and so on. And different clinical risk scenario may pose the patient to different result also as well. And also different angiographic pattern like extent of parent vessel and side branch disease, already well explained, angulations close to 90° or even more than 90°, size of vessel, and so on. Different lesion morphology in stent restenosis. So we have two options. One is, of course, provisional stenting, and this is also already endorsed in the EBC Main. And with this technique, we will have less metal in the bifurcation side. We know that this patient fits also in the inclusion criteria of EBC Main. I'm happy to know that the OCT was used here, and this may lead to two-stent strategy if necessary. So we have heard from Professor Stankovic presentations that crossover from single to double stent strategy is 22% in the ABC Main. So if necessary, we can still use two-stent strategy. We have this flexibility. Kissing balloon technique is of utmost importance in this particular case, where the stent is protruding into the left main. And I do believe that we also need a functional study like FFR or IFR. This will aid our final decision in our approach. Regarding the strategy, of course, there are several options already mentioned by the two speakers. Whether we can use DES with shock depth, for example, Onyx. And for this, probably we need to implant the DES in the left main LCx, because this is the most important vessel very important vessel for the patient, and DEB in the left main LAD, or DEB in the both branches. And we also know that now we are conducting the DCB bifurcation study, where we put DES in the left main LAD, and for the bifurcation, that is the LCx, we use DES. And of course, the other option is upfront stent strategy. This is still a viable option because we know that patient has a left dominant system, and this patient also, the anatomy also fits to the so-called complex bifurcation, as mentioned in the definition trial. So we know also that the circ is very important vessel. So the question is again whether we would like to use the TK cross technique or the recently introduced TK mini colon. But if I have to use this upfront two-stent technique, then I will use TK cross technique, because this is the technique that I'm very much fond of. Thank you.
Okay, thank you, Professor Santoso. How about Dr. Doni Firman? If you have cases like Dr. Fauzi cases, do you have
Thank you, Dr. Munawar. It's really tough case. I hope I don't face this kind of a situation by myself. But of course, we learn from this thing. But if you look at this Fauzi's case, this is 111, I think, Medina classification. And then if you look at the length of the SERP, the stenosis of the SERP is more than 10 mm. So I think the upfront two strategy is unavoidable. I think I will choose two-stent strategy. But the other information that I need to know is also what is the brand or the brand of the old stent, because definitely if you look from the OCT, this is a really under expanded. 2.75 in left main to LAD is really small, so that there's no surprise if you look at the OCT findings. This is under expanded stent. The thing is, whatever strategy you choose, you must be aggressive doing pre-dilatation. So if you look at the diameter of the left main, I think it's 4 or 4.5. So it's not all stent, especially the old stent, have a capacity to overexpand it. It is kind of the diameter. Maybe in the acute result is good, but there's a chance maybe to get let's say stent fracture in the long run. So anyway, if we sure that is a good stent and you can expand until 4.5 from 2.75, So I think I will choose between the crush technique or maybe tap. Look like the angulation between the element to LAD and the circ is also almost perpendicular. So if you have a good preparations, I think still I think the tap is still should be considerable. Thank you, Dr. Munawar.
Okay, thank you, Dr. Doni. And
Muhammad,
yes,
may I make just a comment, because I think Don, if you just mentioned tap, and this was exactly the point. We have a stent in LAD, and this stent is going practically to the left main. And if you stand main branch to the circ, do pot, go to the LAD, close to the carina, treat LAD with drug-coated predolate, of course, and coated balloon, distally 1 stent more, and do final kissing. We have practically one technical approach as a TAP, TN protrusion, practically, or kind of T-stenting. And if imaging will show us good results, so then we will be ready, definitely. So this is the easiest way to approach this case.
yeah. If I saw the lesion, it's actually in the LED, for example, this is extend beyond the old stent. So how the panel is, dealing with the mid LED is actually might be serious problem. Dr. Goran Stankovic, you have a idea regarding that?
Yeah, thank you very much. What I would like to say first, as you mentioned, use of imaging is extremely important. And I'd like to point your attention to evaluation of the protruding part of the stent inside the left main, because you have hanging struts in front of the ostium of the circ, but also use of the OCT may help you, since it's a really long extension, it's several millimeters, it's not so precise stenting at the ostium. I just published in this month in JACC intervention case, very similar to this one, with hanging struts in front of the circ. I used OCT to make sure that my wire will enter the stent and recross into the circ through the struts of the protruding stents, dilate it towards the circ, and then did kissing, and after that converted to mini decay culotte, because this image guidance made me sure that I'm crossing through the distal strut, pushing and removing struts from the ostium of the circ, and then converting to culotte. I think more or less very close to what Dr. Kinoshita recommended. So I just wanted to say, whenever you have stent failure, especially in the left main, I think mandatory use of imaging may help you understand the pathology and the mechanistic explanation, what's going on, so you can base your strategy and select devices according to imaging. And I really congratulate to Dr. Fauzi and the team. I'm really looking forward to see what he did in his procedure. But I saw also that Prof. Murasato raised the hand. So Yoshi, please share your comments.
Yeah, we recommend we respect the minimizing the stent number for this region. So additional 2 stent we we does not agree. So however we fear the plaque burden in the left main to the LAD. The OCT demonstrates a huge plaque burden in the LAD proximal. So we fear cutting down or some balloon dilation inhibit the restenosis at the proximal area. So left main to LCx stent does not work for the proximal LAD restenosis reaction. So we modified the region in the LAD and the left main, and put the left main to the LAD stent and modify the sex region and DCB for the LCx area is recommended.
And may I make a comment?
Yes, yes, please.
Yes, actually, in this case, as I showed in my slide, and most important point is if we cross the wire to the instrumental circumflex, the wire position is very important. As Dr. Mutat showed in his slide, so we try to cross the wire to from the distal, but actually from the angiogram, I cannot understand clearly where wire goes through the strut. So in some cases, the wire, the stent ring is a very link and carina very close, and it may be difficult to open clearly. In such a case, if we plan to stent technique, when we try to the advanced and the stent, the instrumental circumflex, maybe that stent should underexpanded in such a condition. So at first we have to clear. We have to make it clear when we pass the wire. Where is the wire? The wire is we can get the appropriate position when doing it through the strut. If that position is not so good, at that time we have to change my idea, my consideration. At that time we don't need to use the two-cent technique.
Okay.
Yeah, I think we can go now to Dr. Fauzi to see the case, and then we have another 15 minutes
okay,
to continue. Let's see what actually happened, Dr. Fauzi.
Yeah. Okay.
Share your screen.
Yes. So thank you very much for the insightful advice. This is actually the problem is the floating ostial LAD stent from the to the left main, as you appreciate here. So as you observed before from the angio and OCT, there was diffusely disease at the distal stent edge. So we fix distal lesion first. We use a pre-dilatation using scoring balloon because there is a fibrotic at the stented segment. So we use NSC scoring balloon. And then we implanted 275/18 onyx stent as recommended by Professor Ferenc, because this is actually, I'm quite concerned about the bleeding of the hemorrhoid. Afterward, we did OCT before we are dealing with the bifurcations to make sure there is no problem at the distal stent. So the stent looks well expanded. Okay. There is all option on the table. As Professor Goran said, it is better to use stepwise layer provisional. But I think it is not only one stent or two stent. Maybe there is a stentless one stent or two stent. So maybe one option is DCB for DCB dart coating balloon, both left main LAD and circumflex. And the second one, left main LAD stenting and POBA or DCB to circumflex. And the third one is upfront to stent strategy as recommended by Professor Santoso, and maybe others strategy. So what we did, we performed kissing balloon using 3.5 non-compliant balloon at LED, sorry. And then, so that's all after we did cutting balloon. And sequentially, we treat using drug coating balloon 3.5/20 paclitaxel DCB to left main LED, and then 3.025 partial DCB to left main circumflex. Actually, we would like to do a kissing DCB, but concerned about the hemodynamic compromise because long inflations. So we take out the DCB and then we did a kissing balloon using 3.5 and non-compliant balloon LAD left main and 3.0 and non-compliant balloon circumflex left main. So you can appreciate here the result after DCB. Looks all right, right? Acceptable result. But when we perform angio from Rao caudal, show there is some residual stenosis. So post DCB angioplasty, should we stop these procedures and we accept the result of DCB, hoping there is a remodeling afterward, or we proceed to use stenting? This is one discussion. Maybe can I ask the panelists or the moderator?
Okay, thank you, Dr. Fauzi. I think it's a very nice cases, and it look like there is some stenosis still there in the proximal. Do you do with a functional test or something?
No, we not perform functional tests.
Yeah, I think it's we have to invite Dr. Goran, Professor Stankovic. You have any comment regarding that?
Thank you. I have to say again, this is from my personal perspective. I believe this strategy did not remove the floating struts from the left main. So mechanistic problem which created the first instance of restenosis exists. So I will not definitely stop at this point. And I said, I think this needs to be fixed. And there are two options. One, to stent towards the circ and then do kissing. The other one, to stent, as Dr. Kinoshita said, stent the left main and then open struts towards the circ. But definitely leaving floating struts, in my view, is not the best strategy at the moment. Maybe we can hear all the panelists now to share. Maybe we start with Dr. Santoso and listen to all the others just to express for the exchange of knowledge and experience, but also for the educational value for our attendees. I'm happy that 270 people are connected to listen to this one, and I'm sure educational value is very high. So, Prof. Santoso, please share your experience.
Yes, this is a very challenging case indeed. In my view, I would choose to apply the two-stent strategy in this particular case because, as you mentioned, there is stent struts protruding into the left main. So my choice for this two-stent strategy is DK crush technique. Of course, we have dilated the LAD as well as the circ with drug-coated balloon, and if we implant another DES, that means that we double treat the lesion. And there is no such clinical study for this, but as we all know that good doctors always know when to deviate from the guidelines, as Dr. Fauzi used to say.
Prof. Santoso, just for my understanding, when you say now DK crush, does that mean that you will go with balloon towards the circ, crush LAD stent, do the kissing and then stent the circ and repeat kissing? Is yes, this the strategy that you are recommending?
Yes.
Okay, thank you. Just for clarification for me and for our participants.
Yeah, Goran, good point for discussion. Really good case. Congratulations to colleagues. I fully agree with Goran. Struts are a bit partially protruding to the left main, but I'm surprised how good the circ ostium now looked. I was expecting not so good results. So from this point of view, you could go from left, but definitely LAD and this distal constellation, you cannot leave it. You have to go forward. And there are only two options. You go from left main to circ, as I initially suggested, and then do key-sync with ostial LAD, maybe with a larger balloon, etc. And then again, a drug-coated balloon as a last step for this proximal LAD. And then final pod. This will be option. Second option will be to go from left main to LAD, and then pod, and then recross circ and do practically first kissing, and then take a look how it looks. If circ ostium looks okay, though, you could leave it like our ABC study. Then you have only one stent from left main to LAD, one more additional stent.
Yeah, it's my perspective is that for this kind of lesion in very big artery, I agree with Professor Santoso that I do DK cross, and either we cross the stent of the LED and then put the stent from the left main to the we cross then we put the stent left main to the circumflex. That's what we, or we just like DK cross to put the stent first in the circumflex, then cross, then put the stent from the left main to the LED.
Yeah, this is a fear of my the previous opinion. So the proximal LAD and left main still remains a stenosis stentic region. So because of the plaque burden, much more plaque burden located there. So cutting balloon or high pressure kissing balloon inflation could not modify it enough. So in such situation, leave this configuration has a fear for the restenosis in the left main, distal left main. So OCT imaging should be done for assess the necessity to the additional procedure for the left main and proximal LAD. Angiographically, LCx is satisfactory for the opening. So DCB will work very effectively. However, I wonder the efficacy of the DCB in the distal left main and the proximal LAD. So imaging should be done for the next step.
Yep. Thank you for the nice case, for your nice case. Actually, I completely agree with Dr. Murasato. I want to know what happened in the this part, this just proximal LAD. Why this stenosis occur? I really want to know if the stent still now showed under expansion. At that time, we have to dilate more and more with high pressure, and but so there is some if there are some plaque burden in the hand here, even the stent is fully expanded after the full expansion of the stent. At that time, we have to remove the that plaque burden, or we have to compress that plaque burden. So actually which way is better for this region to decide to that which is better. I strongly recommend to use the OCT or IVUS again to this region.
Okay, and let's finally see if the president of the society, Dr. Firman, knows what his secretary will do in this case.
Thank you, Goran. So anyway, so I think, of course, I'm not stopping in this point. Even the pressure wire showing okay result, because there is not so many data or weak data regarding the DCB in the bifurcation, the left main bifurcation. And the second, I must note that the patient coming with acute coronary syndrome, and Fauzi also mentioned that the culprit might be in the ostial obstruct because he found some thrombus in the ostial obstruct. So definitely, I'm not living in this kinds of situation. And then I still think that I really agree with Dr. Kinoshita that we must do another OCT run and then see what's happened. And then in terms of your strategy, and I still think that the two-stent strategy is unavoidable in this kind of situation. That's all, Goran.
Thank you so much.
I think so. We proceed to Dr.
Time
Fauzi.
for the truth. We go to Dr. Fauzi to see what he has decided.
So at that time, we consider this is an suboptimal result after DCB. And as Professor Friend said, there is a very amazing ostial circumflex. So using the imaging for that time is not possible, is not going to change the decisions. So, and two-stent technique maybe should reconsider because the ostial circumflex looks nice. So what we did is putting a 3.5 3 millimeter resolute onyx deployed in left main LAD to 18 ATM. And then followed by part 4.5 12 NC balloon to 18 atmospheres.
Yeah, I absolutely agree so far. I said this exactly meets the stepwise provisional as a strategy also for restenotic lesion.
Yes.
Just to clarify for the colleagues, EBC main did not include restenotic lesions, but we tried to promote philosophy of a stepwise layered strategy, adding complexity, starting with the main vessel stenting, then doing pot, and then doing kissing. So that's why I said this is exactly aligned with our promotion of the layered stepwise strategy. So please go on. I think looks beautiful now.
So look at the circumflex, the flow to grid. It's not compromised. So the problem is after pot, should we treat the ostial circumflex or not? Should we stop at that point and accept the result?
This was the criterion compromise of the flow in the EBC main and in our philosophy, compromised flow or extremely tight stenosis of the side branch, which most probably in this case was created by the two distal pot position and shift of the struts towards the circ and therefore compromise of the ostium of the circ. So in our view, it's relatively straightforward. We continue with kissing, and of course after pot we need to cross distal cell. We continue with kissing and we try to evaluate result at the next level of complexity. This is just the first level, main vessel stenting and pot. Now because of the compromised flow, we add level of complexity. We do now distal recross, we do pot, we do kissing, and after kissing we evaluate again. If needed, we can always add the second stent as T, TAP, or culotte, depending on the operator preference. So I don't know if anyone else would like to comment at this level.
Dr. Sunaria maybe have any comment.
Sure.
Thank you, Dr. Fauzi and all the moderators. I think the step-by-step provisional stenting as in EBC is very good to apply in this case. Of course, after this, I think recrossing the circ and open up the strut to the circs may be the other option before we do kissing balloon. Thank you.
Maybe there are some questions from the audience. Maybe you could,
I answered two questions.
Okay.
Yeah, I answered two questions online. One was about trifurcation, and I said that in view of EBC, for us, trifurcation has the same roles of the fractal geometry, just modified for trifurcation, but stenting strategy is very similar. We have just one more additional wire in the third branch. And at this point, Someone also suggested DK crush, as Professor Santoso did, crushing the LAD stents and converting to DK crush. So these are the two questions. If there are other questions, please go on.
One question, Goran.
Yes.
You know, this part is very easy to say. You know, in the consensus, 15 consensus of EBC, we have to put at the carina, but it's not easy to put the carina.
Exactly.
I mean, that's how to, you know, I mean, that's nowadays is with the 3D OCT, we can exactly to see the crossing the wire, but to put the balloon at the carina is not easy. Is any tip and tricks?
Yes. Thank you very much for this question. So first of all, like in every bifurcation, we should try to select the view in which we really have the most widely open bifurcation. If we are dealing in this case with distal left main, it's most probably spider view or LAO caudal, because we decrease the amount of foreshortening so we can really see clearly carina. And second, after stenting towards the LAD, we push a wire which is jailed into the circ. So position of our distal marker of the balloon should be beyond the crossing point of the two wires. So recrossing point of two wires is proximal to carina because of the stent pushing wire against the lateral wall. I'm sure it's not simple. We need to know first the relationship between the shoulder of balloon that we are using and the distal position of the marker, which is different for different manufacturers. But in any case, it's very dangerous after crossing to be in front of the carina, not to cross the carina, because by crossing carina, we push metal and now we compromise the ostium of the circ with metallic struts from the main vessel stent. So position the distal marker in front of the carina in the position and geographic in which we most widely open bifurcation angle, and in this case should be LAO caudal. This is what I would do.
In the resume, I think it's just angiographically we can do as best as put
exactly.
at the...
Exactly.
One other option is to use a clear stent function or stent boost is also really helpful if you have this option in your cath lab. So at least I use it quite frequently, and it's helpful to try to find the best position for the balloon marker.
Yes, I agree with you. When the two artery has two stent, that's very easy to do. But if just like one stent from left main from LAD to left main, might be difficult to put in the carina.
In front of the carina, not
in front of the carina.
Whenever you go, you know, when you start inflating balloon, first you increase diameter in the axial direction, but as soon as you feel resistance, you have also longitudinal balloon expansion. And with that longitudinal expansion, you push carina.
And then we decided to keep dynamic nature of bifurcation anatomy, which is to place the carina at the center. So we rewire the circumflex using an angiofluoro guided. Our OCT is old-fashioned machines, so has no feature 3D construction to use online construction to assess guide wire recrossing. But as you identify here, when we recross, we identify this is the wire went to the proximal part. So, okay.
Yes, we can see.
So that's why we, that's why we repositioning to distal. And then after open the strut using 20 millimeter balloon, we did kissing balloon using 3.5 NCD non-compliant balloon at the left main LAD after sequential balloon dilatation. And then we did kissing balloon. And final pot using 4.5 travel, as you appreciate here.
Yes.
So this is the final result.
Yeah. Yeah,
and
much,
this is the
much better. Yeah.
OCT. OCT pullback showed the stent looks well expanded. Look at the ostium circumflex afterward. So at the circumflex now start overlying in the ostium. Right.
Excellent.
This is the MSA at the left main MSA ostial LAD. We can accept this MLA MSA 5 quite close to the 6 millimeter square, and this is no overlying strut in the ostium circumflex.
Excellent.
That's all.
Thank you very much, Dr. Fauzi.